So I kept the date as ENMG Vignettes. So I'll start with a brief introduction before I go into the cases. And then a few basic principles I'll just highlight, then go into the data. I set around 20 graphs or videos for interpretation. This will be followed by answers for the previous data and explanations, and there may be additional graphs which I'm going to show for highlighting the abnormality or the phenomenon. So first thing what we need to understand is that what is the test modality that is given. Suppose you're given a graph during examination or during the rounds and you're asked to interpret. Now what is the test modality? You have to understand. Then to interpret the graphs, you need to know what's the sensitivity, and to the time domain, the sweep speed or sweep duration, you need to know so that even if the data is not given, you should be able to judge how much the latency, amplitude, duration of the trace that is given. Then you have to identify whether the data or the information that is given, provided, is it within the normal limits, or is it normal variant like in EEG, or is it abnormal? And if there is any technical abnormalities or pitfalls that has been conducted or performed by the technician who has done, that you should be able to identify. I'll be showing only one of them for the pitfalls, but subsequent most of them are looking at the normal or abnormal phenomena in the EMG and the conductions. This graph, all of you know, simple nerve conductions, motor nerve conductions starting from median the wrist to the Ebbs point. What we see is that all the traces are almost identical, and when you go from distal to proximal, because of slight degree of temporal dispersion due to variation in the fast and slower conduction motor axons, there's going to be slight increase in the duration of the same map and very subtle, usually less than 5 to 10% reduction in the amplitude. That is normal. And if this phenomenon is not seen, there is a sudden decrease in the amplitude, like what we see. This is in ulnar conduction, bilateral ulnar conductions at wrist below elbow, and as soon as we go above elbow, there is a drastic reduction in the amplitude, demonstrating there is a pathology across elbow. This was bilateral. It's a patient with hereditary liability for pressure palsy. So this is what you have to see. This is the linear change in the amplitude and in the duration, whereas the abrupt change is what we look for the focal abnormalities. There is a non-linear change. That's number one. But when you go to the sensory nerve conductions, here we have the players from the fast conducting fibers, slow conducting fibers, even up to 4 microns in diameter. Because of that, there's going to be a lot of temporal dispersion. As you see, this is the recording from the digit 2, and when you record the stimulated palm, wrist, and going proximally, you see that there's a marked reduction in the amplitude. Velocity remains the same. So this phenomenon of the reduction as you have the increasing length of the axon and the nerve being tested, this is a normal phenomenon. Whereas if the same thing is seen in motor, this is going to be conduction block or conduction failure. Recording electrode makes an important change. Suppose we change the recording electrode like you see here. This is for the simple median. We have recorded from 4 sides across almost the belly of the muzzle, and all of them look almost the same. But if you look at the amplitude, there's almost a reduction of almost 40% when you change if you place the electrode in the wrong position. So the optimization of the recording area site has to be done correctly, and if there is an obvious apparent reduction, then you have to try to change the electrode recording site and try to get the better amplitude. As important as the recording electrode, the active electrode is a reference. Now this is with the shorter interrotatory distance, almost near the tendon of the ADM that we have put the electrode, we see that the response is slightly small, but when you go to the distal portion, the fifth metacarpal head, you see that the amplitude become bigger. When you increase the distance further, it did not make a difference. But what we see here is we can see the biphasic response or the serrations in the upslope or sometimes the downslope of the CMAP from ulnar. That is how we can identify that it is ulnar or CMAP. When we change the electrode, reference electrode to the proximal portion, we saw that the morphology has completely changed. This is due to interplay of the other muscles in the hand, but the same thing happens for the amplitude when you change the reference electrodes. And the similar thing is seen for the active electrode for the motor. So we see that the amplitudes are almost same for the two sides of reference. So we'll see two examples now for saying whether it's axonopathy or no axonal loss. Now, if you see this data, I will try to show that now 6.4 millivolts for ulnar now is good enough. Distal latency is slightly prolonged. If you see, it should be less than 3 milliseconds, but the distal latency for our lab is this for the 1.34 milliseconds, whereas the duration is normal. We see the amplitude velocity is 47, 45. This is still acceptable for ulnar now. For identifying whether it's normal or abnormal, this is going with absolute amplitude. This is normal. We go to the opposite side. Morphology is the same, good morphology. We say that the opposite side CMAP amplitude is double, 12.5, 12.3, 11.8 when you go proximally. And there is no conduction failure. There is no slowing here. In the pathological side, abnormal side, there is a slight slowing across elbow. But the pathology was not at elbow, but the lesion was much more proximal. This person had thoracic outlet syndrome. There's axonopathy. When you combine right and left, you can see the two graphs, overlapping graphs. The normal side is the blue, black is the abnormal side, which shows there's a reduction in the amplitude. So side to side compare different companies show in a different manner. They can show side to side or overlapping. We can make out by the morphology and the amplitude whether to say more than 50% if there is a reduction in the amplitude, we are going to say it is normal. This one more example, same person, median now, stimulation, we say that the morphology looks relatively okay, but if you look at the amplitude, it's a half a millivolt, distal latency is normal, and velocities are just moderate and reduced in the forearm segment. And another more thing which I would like to highlight and show is that in the median nerve stimulation, when you do, there can be a small nerve action potential because of the recurrent nature. Like the median nerve goes to the palm and goes back into the APB and the thinner muscles. Because of that, you may see a small nerve action potential. This is normal, but only thing is see to it that they don't place the cursor over the nerve action potential for the latencies. Now, this amplitude is definitely reduced compared to the normative data. Opposite side is 18 millivolt. 18 millivolt, this is comparable with the ulnar CMAP, the same patient. When you superimpose right and left, you can see the difference. So there is a different axonopathy more in the median now compared to the ulnar nerve. So very brief highlight regarding the EMG. You are putting the needle into the muscle. This is in when you look at this, all muscle fibers in the from the side. So we have the needle electrode, you have multiple muscle fibers, and in the cross-sectional area, the relation of these muscle fibers is some of them are near, some of them are far. Whichever muscle fiber is further away will be producing a smaller potential, and depending on the length of the axon and the diameter of the muscle fiber, some of the single muscle fiber potential, they'll be reaching the needle earlier, and you combine them together, you get a same the motor unit potential like this. Or it can be single fiber potential like a single end plate spike or fibrillation potential. One more thing you need to understand when you look at the EMG, This is the conventional H&D section of the muscle. That is with the ATPase and enzyme studies. Now we see that there's a lot of overlap of the muscle fiber. There's a type grouping. It's not there. The different type 1 and type 2 muscle fibers are interspersed. And among the type 1 and type 2, all of the muscle fibers will not, from the same unit, are not going to be at the same place. So this is a caricature to show that there are five colors in this caricature, which shows that there are five motor units which are interspersed. And when you have the needle electrode put into this the muscle with the more five or more motor units, the fibers which are the nearest, that is within half a millimeter from the recording electrode, they will be contributing to the spike of the MAP and also for the amplitude. And moment you change if this electrode position is changed by a fraction of a millimeter, it may be in contact with the one or less two muscle fibers, sometime more than that, which will produce the bigger potential or the smaller potential. If the only one fiber is there, this potential is going to be small. If there are more five or more, the MEP amplitude is going to be much bigger. And depends on where you are in the motor unit. If you are further, for example, the needle is somewhere here in the bottom, here hardly you have any muscle fibers. You have only one here, so amplitude is going to be smaller. And the periphery, the muscle fibers which are further away, they will contribute to the duration. So any minor change in the needle position is going to change the amplitude, whereas the duration will remain the same. I'll just play a short video. I think I'll have to. I'll play it once more. This is the same motor net. So what you can see is that when the needle position was changed by a millimeter or so, the amplitude increased, duration remained the same, firing rate remains the same. If we see in the top, this shows that we have amplitude which is big, then became smaller, smaller, then again big. So any minor change in the needle position will change the amplitude of the motor unit potential. The duration will not change. Okay. So before going further, we'll just go through one video. So we are seeing this light, but not the sound. Now the same video, if you do not have the audio signal, it is very difficult to make out what is the signal. The firing pattern becomes difficult. Sometimes there are overlapping signals, and what looks like a fibrillation may not be a fibrillation, it may be end plate spike. So it's always better to have EMG sounds along with the video of the recording. So with this foreground, I'll start with around 8 or 10 videos of EMG. This is the first example. You can note down their answers. We'll come back to all this later after the play of the video on the video center app. Now sensitivity is mentioned here, 100 microls per division and 10 milliseconds. My videos of EMG are 20 divisions, so this displays 200 milliseconds. So we'll play it once more. Okay. Then we'll go to the second one. So this 200 microvolts, 10 milliseconds per division. So third video, I've taken only the typical ones for the time being. So 50 microvolts per division. So top to bottom is 500 microvolts, and we have 10 milliseconds, like 200 millisecond pattern. This is 100 milliseconds per division. So in other words, from beginning to end of this video screen is 2 milliseconds. Okay, we'll go to the same thing in a different color. Number 5. So this 10 millisecond per division, 200 milliseconds. To identify the abnormality. The number 6. Great one. So we have to identify what is this activity and say whether this one is normal or abnormal signal. This is 5 milliseconds per division, so total duration is 100 milliseconds. This is with superimposition, cascade display, and superimposed to show that the waveform is consistent. So number 8 is one more EMG video. Sensitivity here is 5 millivolts per division, 10 milliseconds speed. So this speed, otherwise 200 milliseconds is the total speed. Okay. Number 9, you have to comment about the activity and if possible the firing rate and say whether it's abnormal or not. I have frozen the screen for your benefit. This is 200 milliseconds from end to end. So whether this is normal firing or normal activity or abnormal activity. Here you have to identify 3 findings in this video. Normal phenomena and abnormal phenomena. Two findings are very, very evident. Third one may be missed, but let us see. Okay. This is recruitment or interference from a limb muscle. So 50 microns per division. So total amplitudes covered is 500 microns from top to bottom and 50 milliseconds per division to show the condensed recording of the EMG. Okay, this is a screenshot of the flows stop screen from recruitment analysis. 100 milliseconds per division, so that's 2 seconds data. 2 millivolts per division, so top to bottom is 20 millivolts. So this is one in comparison to the previous one. So recruitment and interference pattern. Okay. We'll come to the conductions. I started with the FA study. In last week, there's a lot of discussion regarding the F waves. We can see the sensitivity is mentioned here for 8 milliseconds per division. So from here to here is 80 milliseconds. This right median now, and sensitivity is 3 millivolts per division for M wave and the F wave. So is it normal? And if, or is it abnormal? If it is abnormal, what are the abnormalities? There are two abnormalities in this graph. So FA study, there's no doubt, but type of abnormalities is for median now, FA. So this patient was undergoing now conductions, ulnar now conductions. Now we do not have the distances and the conduction velocities. I'll just zoom the graph for your purpose. Wrist, first is the wrist, then below elbow, above elbow. The baseline is unsteady because of the little bit of 50 cycle artifact, and the sensitivity was 0.3 to 300 microns per division. So is the conduction abnormal? And if there is an abnormality in the data, we'll just show you the data here. 200 microvolts is the CMAP amplitude, then 140 micros, then 250 when you went to the proximal site. And latency, distal latency 7.17, below elbow is 32 milliseconds, above elbow is 35. So what is the first preceding potential before the ulnar CMAP? There is one to be found out. And in addition, what is the type of abnormality? Is it, where is the pathology? You have to document. This will skip, okay. So median of conduction, this patient, median of conduction from wrist, elbow, arm, and Ebbs point. We have the amplitudes 9.5, 8.5, 8.5, then 0.65. Now this conduction was done 3 months after the brachial plexus injury. This person has fallen down. What's likely to be the outcome of this patient, and what's the abnormality shown? So we have distal latency normal, amplitudes are normal distally, and we have a abnormality on stimulation at elbow, F's point. This another patient with weak hands, rapidly progressive weakness, around 2 months or 3 months was the weakness symptom. And this is the conduction showing, let's show the latency 7.69, 0.4, 0.44, and when you went to the axilla, it's a 0.04, that is 43 microvolts is this thing. And duration, it went on reducing. Velocities are here for you. Forearm segment across elbow and in the arm segment. So this will not zoom further. Then you have to look at the graph. So what is obvious, we have shown you the numerical data. Then you have to comment on the waveforms that you are seeing at wrist, below elbow, above elbow, and in the arm. So there are 3-4 abnormalities which we are going to document and tell us. So this is a median of conduction. We did the incremental, gradually increase the intensity like what we do for motor nerve conduction. You're not going to go directly for the 20 milliamperes, 30 milliamperes, then stimulate. We usually start with the low intensity, and this was the result. We gradually increased the intensity from 1 milliamperes to went on till 10 milliamperes. So what is the abnormality seen? This person has had quadriparesis with the wasting of the hand muscles with brisk reflexes in the upper limbs and lower limbs. So brisk reflexes, quadriparesis, hypertrophy in the hand muscles. So we have the sensitivity is 2 millivolts per division. This is the maximum here. This is just one division. So the amplitude will be around 2 millivolts or just barely 2 millivolts. What is the abnormality demonstrated? So last but one, we have other now conductions with the stimulation at wrist, below elbow, above elbow, and arm. So we have to look at the graph. What is happening in the graph? Then, sorry. We have the numerical data, distal latency, then amplitude, 1.6, 1.12, 0.55, 0.42. Then you have the velocity, which is there, and amplitude decrement when you go from distal to proximal, like that. Okay, last one is straightforward. So this is repeated nerve stimulation, 10 stimuli, 10 of 10 at 3 Hertz. Concentrate on the first one, second, third, then maximal voluntary contraction for 20 seconds. So what is the abnormality shown? And what is the where is the pathology? Is it presynaptic, prosynaptic? You have to tell us. So 3 Hertz. Now this is the post exercise 3 Hertz stimuli for 10 stimuli, but we have the preceding one which show the graph. We have the abnormality with or findings which are mentioned here. Then after exercise, then subsequently at 5 minutes. I think that finishes the cases or the graphs. So we can start with the interpretation if anybody is ready.
I think you can go ahead, sir. There is
Okay. Okay. So this cartoon or the small diagram was shown in the last class, and this is one from the Mayo Clinic from Jasper Darby and Rubin. It says simple classification of the EMG signals, very regular linear changes or no change or minimal change is fibrillation, positive sharp wave. Irregular, very regular, no change. This is going to be a complex repetitive discharge. Regular, but with the exponential change, sudden increase or reduction, myotonia. Irregular, random change is end plate spike. Semi-rhythmic, it sounds similar, but there's a little bit of variation. That's MAP. Then you have bursts occurring, the EMG signals occurring bursts or myocardia. So this encompasses almost 90% of the signals. So we'll go to the first one. So this is the first one is the fibrillation. Why is it fibrillation? It is fibrillation because the firing is regular. If you see the spike intervals, they're almost at the same time. And when you use the sound, it's almost unchanged. Very minor variations are there, but the interval between the each type is same. And why it cannot be MAP? It's possible that this could be MAP, but the reason why it is not MAP, not energy potential, is the duration is short. Anything from a single fiber potential, let's say a single fiber potential, is usually less than 5 milliseconds, except the facial muscles, which are small muscles, and in the muscle motor unit, you have 3 to 5 or maximum 10 muscle fibers per axon. Whereas the limb muscles usually have more than 50 to 100, sometimes going up to 1,000 muscle fibers in a single motor unit. That's why the MAP duration in the limb muscles is going to be 10 to 14 milliseconds, depending on which muscle are you looking at. And here the potentials are very small, around 3 milliseconds. If we see from here to here 3 milliseconds, all of them are the same. There's no variation in the amplitude. And the interval is here is 40, 42. Again, here is 40 milliseconds. So variation is very, very minor. It's not very highly regular, like what you see in a complex repetitive discharge. So this is a fibrillation. Duration is very short, very crisp sound. So use of the speaker is going to be useful. Now, in comparison with this, here is one more single fiber potential. This is going down and up. Down is fast, going up is slow. Now, this is a fast sharp wave. We have one more which is slightly further away here. This one more fast sharp wave, this one more. These are from a muscle fiber which are further away. This is the one which is from nearest to the muscle recording electrode. And here you have a fibrillation potential, which is just after that. We'll just play this. The firing is very, very regular. Sometimes the fibrillation can go on to become a fast sharp wave or vice versa, depending on how you are recording. Duration is 5 milliseconds. You can go up to 30 milliseconds or 40 milliseconds. Now, if you see this fast sharp wave is from 1, 2, 3, 4, 5 divisions. 5 divisions, 50 milliseconds. So it can be as long as it's supposed to be due to the injury current to the single muscle fiber. And both can be combined together. Fibrillation. So this is a combination of fibrillation and positive sharp waves will occur in neurodenervation after 2 to 3 weeks, not earlier than 2 weeks in most of them. And most distal muscles is going to be after 3 weeks. If suppose you have a patient with brachial plexus injury or sciatic nerve injury, Hand muscles will show after 3 weeks, whereas a proximal muscle will show in the brachial plexus for at around 10 to 14 days. And lower limbs is going to be much more later. Now, grading will change. Many books mention 1 to 4, grade 0 to 4. That's a good option. Other option is how many sites did the where the this fibrillation positive sharp waves has seen. That is another way of saying out of your checked in 10 sites, if 10 out of 10 sites have shown this fibrillation of positive sharp waves, that shows much more extensive denervation in comparison with only one site or two sites. Now it may fill the screen from the if you say grade 3, it is filling the screen according to one's classification. But if this was seen only two sites out of 10 sites, the extent of denervation is not that much. So there is the one which I prefer to use. Okay. We listen to this graph video. What is evident is that you can see one spike here, second spike. There's a big gap of 30 milliseconds. Then within 10 milliseconds, you have fourth spike, 25 milliseconds. Then around 60 milliseconds later. That means the interspike interval is highly variable. It's a chaotic rhythm occurring very, very unpredictably, not in the not the spike, not like the fibrillation that we saw. So this is a end plate spike. So this irregular spike, the sound will be similar to the fibrillation potential because these are coming from a single muscle fiber. It is due to irritability of the muscle fiber, especially if you are near the end plate zone or near the end plate. So try to, if you are doing away from the end plate zone, fibrillation, I mean, the end plate spikes may not be seen in a common fashion. This is a fasciculation potential. So, okay. So this is a big potential here. Multiphasic, polyphasic, duration around 1, 2, 3, 30 milliseconds, 40 milliseconds. Amplitude is exceeding the 500 millisecond peak to peak because this is exceeding the uh, capacity of the screen. When you go further, I'll just show the next one. These are irregular occurring due to the denervation. Here is a different one. Third type. This looks like MAP. Previous one looked like a polyphasic. This looks a polyphasic MAP. How are you going to differentiate between MAP and the fasciculation? Differentiation is by the firing. Fasciculation potentials occur very, very randomly. They do not have rhythm. It can occur at any time. The firing rate, even if it is so rapid, it will not be more than 5 per second, whereas generally the MEP firing will start around 5 per second, 5 hertz, then can go up to 15 hertz. Here, anything less than that. Now, this person had around 5 or 6 fasciculation potentials in the whole of 1 minute. In addition, there is some distant fibrillations which are not very near. These are likely to be distant fibrillations, not very near. So this we are going to ignore. We are going to concentrate and say there's a fasciculation potential. It is easy to identify the fasciculation potential when the person is relaxed and is not contacting the muscle fibers. But it's not possible always for the patient to relax completely. Now here if you see the waveforms, there is a lot of noise. Now this noise is not due to the amplifier. These are due to the distant muscle fibers. If you can see, these are distant muscle fibers, we'll see whether we can identify the fasciculation potential. It's still possible. Distant MEPs will not be heard, they are going to be seen because they are away from the recording site. This random sounding signals can still pick up the signals, fasciculation potentials. They need not be always very big. Now you can see that the MEP are seen slightly better, still not very good. The needle is being slightly withdrawn. Now we have one MEP here, second, third in the first trace. Then you have 1, 2, 3 MEPs. Now in the top we have two types of MEPs. One, this is the second one. Here, second trace you are seeing two MEPs. Third one. Now in the third trace, we heard the sound. This is a fasciculation potential. We'll try to play this once. So you should be you can't expect the patient to completely relax always. It's difficult for many people to relax the muscle during the muscle contraction. So it's like listening to a musical instrument during a symphony or musical this thing program. You can differentiate between different types of drums or different types of string instruments. You'll be able to identify. So similarly, you should train your ears to identify. Now, this person has bursts of EMG signals. This is doublets, 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 then triplets here. We'll see how it sounds. Now, these are occurring in small bursts. Now, how small is this burst? This is 100 milliseconds. Each division here is 100 milliseconds. That means this burst is around 50 milliseconds. This is also 50 milliseconds. So it's not a very short burst. It's a 50 millisecond burst. In addition, the patient had fasciculation. Sometimes the one of the motor unit potential which is in this march can be missed. For example, this has 2, this has 2, this has 3. Sometimes it can be 2, 3, or complexity can vary, but again, this is irregular, not completely regular, and is called to be supposed to be called as like marching band. So one can be simulated by very slow tremor, but again, the frequency you have to see from the beginning to end here is 2 seconds. In the 2 seconds, you have 1, 2, 3, 4 such 5 signals. Okay, here 1, 2, 3, and 4. Sometimes 4, sometimes 5. The tremor will not be so irregular. The almost always the tremor is going to be regular. If it is a genuine tremor, pseudo tremor, or the hysterical tremor will be irregular. And the EMG bursts are going to be much more longer, about 100 milliseconds, 50 to 100 milliseconds. Whereas my KMH can be short or it can be long, and sometimes you can having a missing of the MEP from this thing. This is CRD. This example you have heard. This the person is activating the muscle. There's firing, spontaneous, the voluntary firing of the MEPs are there. Now, how much is the interval from one to the second one? This is 1, 2, 3, 4 length. So from one burst spike, you have about 20 milliseconds. So 20 milliseconds is from one spike or one set of spike to the second spike, then to the third one. then fourth, like that. This is due to overlap here. Around 20 milliseconds is the inter-spike interval, interburst interval. So if in 100,000 milliseconds, it's got around 50. So 50 hertz is the firing rate. So 50 hertz, and it's not waxing and waning like in myotonia. High firing rate is not reduced, so it's a complex repetitive discharge. Why does it occur? It's because of the CRT circuit. It's called a pseudomagnetic discharge. The single muscle fiber, it goes on stimulating the adjacent muscle fibers, and finally the signal comes back to that. So it's called as regular firing, abrupt onset cessation, 30 to 40, it can go up to 50. It can be single spike or polyphasic. Amplitude one can go up to 500 microvolts. It's called as almost machine gun sound or jackhammer. It's like this, like a WhatsApp message that you send. It goes on and finally it comes back to you. This is neuromyotonia. Very rapid, 10 milliseconds interval from first spike to the second one. You have not around 8 milliseconds. Now, from here to here is again 8 milliseconds, again 8 milliseconds. 8 millisecond dividing 1000 is going to be 125 hertz. This is one of the fastest firing. It occurs abruptly, then stops abruptly because the muscle fibers are not able to sustain such fast firing rate. So we'll listen to this one. Started abruptly with the needle movement. Once you hear, you will not be able to forget, and it's quite difficult to record this because unless you keep the recording on in the screen. This is normal MAP. When you look at this, we have this signal which is occurring at recorded at 5 milliseconds per division, 300 milliseconds per division. So this amplitude is 1, 2, 3, 4, 5. 5 divisions, 1.5 millivolts is the amplitude of the MAP. Duration is around 8 milliseconds. So if you see this, 5 milliseconds here, then around 3 milliseconds here. So 8 milliseconds is the duration. We'll see the firing rate. So when this is firing in this 200 milliseconds, it is occurring not more than once. On 100, not 200, 100 milliseconds by 20 divisions. So the firing rate is not more than 10. If this had occurred more than 2 times in this 100 milliseconds, firing rate would have been more than 10. Less than that, it's either 10 hertz or slower than that. So this is with what we call as a cascade display to demonstrate that is the same type of discharge without any change. And this is to show the superimposition and to say that there is no variability in the motor unit potential. And this part is recorded at 2 millisecond per division. So this is 1, 2, 3, 4. 4 is 8 milliseconds is the duration, as we saw in the previous recording, part of the recording. Now firing is 8 hertz. So 8 hertz, it has never occurred more than 2 in this 100 milliseconds. The firing rate is less than 10. So 8 hertz is the firing frequency. So this is a normal motor unit because duration is 8 milliseconds, amplitude is around 1.5 millivolts, and firing rate is 8. So this is normal MAP. So next one is giant MAP. Why it is giant MAP? The 5 millivolts per division. So that means from bottom to the top is 50 millivolts. This is a huge MAP, and duration is 10 milliseconds, the sweep. Now we'll just see with the what is heard is it is irregular, not very regular, but not as irregular as the end plate spike. We are seeing three waves here in 200 milliseconds, but sometimes two. So 2.5, the firing rate is going to be around 10 per second. Okay. So when you see this, top to bottom is around 7 divisions here. 7 into 5 is going to be 35 millivolts. 35 millivolts is a giant MEP. Any motor unit potential more than 5 millivolts is a giant MEP. It occurs with reinnervation. A stable chronic reinnervation will have a large potential, and amplitude duration is going to be large amplitude and normal duration. Whereas a reinnervation, when it's occurring very gradually, and when you record before it's completely stable, you can have unstable MEP and polyphasic MEP gradually becoming shorter and shorter. And it's like you making a pillar out of small bricks, the bricks which have been placed on the ground. You have 10 bricks side by side, they are 10 bricks across, one brick height. But if you stack one after the other, you have 10 bricks, that's one above the other, but one brick across. So the amplitude also is same thing which occurs with reinnervation. So this is superimposed. Value is, we measured it as tentatively as 35. Now it's 37 millivolts. Duration is around 9.56. So it is almost 10 milliseconds duration. It's a normal duration, but very, very large amount. This person had anti-Honsel disease, chronic, going on for almost 1 year. So MEP with high firing rate. What happens when the motor unit starts firing with the minimal force that is required is it starts generally at around 5, then gradually increases. When it crosses around 10 hertz per or 12 hertz, the same motor unit is not able to sustain the force that is required. So second unit is brought forth, and when the second unit becomes around 10 hertz, third unit will come. That's how the recruitment occurs. Now this will play this. So here in this 200 milliseconds, we have 5. So obviously, when you multiply it into 1 second is going to be 20. 20 is fast. So more than 15 should not occur. Here you have 6. When you look at the interspike interval, interburst MEP interval, some of them are 20 milliseconds, some of them are around 40 milliseconds. It is varying. There is a pseudo-random firing of the motor unit potential. So this is a normal firing pattern, but the variation is that the firing rate is high, sometimes going up to almost 40 hertz. If you see, look at this signal, 20 milliseconds interval. So 20 dividing 1000 is 40, sometimes almost 20 per second. So this is what you have to see. And even when this single poor MEP is firing, there is no other MEP motor unit which is firing. So this person has a long-standing chronic neurogenic disorder with markedly reduced motor units, because this is what I identify. If the firing rate is more than 15, the second unit should have come, which is not occurring. So this is the motor units are reduced. Now, the amplitude is not very big. It's a MEP duration is normal, MEP amplitude is normal. Not only look at the amplitude, duration, but also look at the rate. That's going to tell us more. So this will play once more. So what is seen is we have polyphasic. Everybody would have identified this. There are two more findings which is to be seen. cascade display. Okay, now coming to what should be the measurement. Now, clearly it's a polyphasic MAP because here one, two, one deflection below, one above, down, above, below. So about 10 to 12 phases are there. Now, what should be the duration? Duration will start from here, then go till here, or should we go till this small spike which is time locked? You would have seen that this is a occurring very, very regularly. Sometimes it can occur much more closer. So this is a satellite potential which we are not going to take into consideration. Even if it has come much almost here also, we are not going to take this into the consideration for measuring the duration. Because if we take this satellite potential into consideration, your measurements are going to become completely haywire. Another abnormality, now this is one polyphasic MAP clear cut. Second is the satellite potential. One more. Okay. Now listen to the sound carefully. There is one single polyphasic fasciculation which occurred here. Somebody, at least one of you or more than one of you would have probably heard the sound of this. Yes. So even if the MEPs are firing, you should still be able to identify the fasciculation which is occurring randomly. Out of the whole video, only a single fasciculation potential occurs. So denervation is there. Now, the reason why you should not take this satellite potential into consideration is this is due to a very long muscle fiber or the axon, which is quite away and innervating the muscle fiber, which is quite at a distance. So this you are not going to take into consideration. You are going to take only the muscle fibers which are in and around this thing, so that your measurements become simpler and not contaminated due to the satellite potential. So how are you going to take the measurements? This is a revision for everybody. Measurement is peak to peak. Very simple. The lowest nadir, that's the topmost portion of it. It's a simple MAP or a polyphasic MAP or much more complex MAP is going to be peak to peak. There's no controversy. Unlike in motor conductions where you're going to take either baseline to peak or peak to peak depending on the lab. So duration, yes, onset, the deflection from the baseline to the deflection. Now, the newer equipment will identify this duration. Sometimes you'll have to override. Area, this is the one which is going to be above, below and above the baseline. This you don't have to calculate. You cannot sit and calculate because the machines are much faster. Amplitude, duration is supposed to be the most sturdy measurement. But unfortunately, it is the most difficult one because this is 1, 2, 3, 4, 5, 6 people were given. If you see, there are 6 cursors here. 1, 2, 3, 4, 5, 6 cursors. MEP is given to the experts. There are variations. Now you can see a lot of variation is there. Some person is going to put here, some person is going to put in a different place. When the slope is very easy, it's fine. It's a steep slope, but when you have a very slow slope which is going up, the duration measurement is going to be difficult. But the recommended thing is that you should measure the duration at 100 microvolts per division. Variation is going to be there. So there's one thing that you have to take time to measure the durations. So with the single MAP, it may become difficult when you have this. If you have an averaged MAP, it is much easier. Otherwise, superimpose the MAPs and then take the duration. It becomes much easier so that this confounding small adjacent multi-unit potentials, if they are overlapping the MAP that you are measuring, then it's going to be difficult. So superimpose them, try to measure. And when you go for, you take multiple MAPs, then take the duration. Duration is 14 here in this muscle and amplitude is 4.3 millivolt. This is definitely pathological. Some potentials above 6 millivolts, some of them 1.7. And polyphasic MUPs should be less than 20% in most of the muscles. And as the age advances, polyphasic MAPs are going to be more. So 43% or 44% polyphasic MAP, long duration, large amplitude is a chronic neurogenic pathology with the reinnervation. In comparison with that, we have around 61 MAPs. Among that, you have duration is 5.2, amplitude is, if you go by the classical publication, 386 microvolts is normal mean amplitude, and the mean duration of 5.2 is 50% less than the what is recommended. So we have, this is a very short duration motor unit potential. Now, if you look at the amplitude cloud here, you have from 0 to 20 milliseconds, 90% of the MAPs are to the left of 10 milliseconds. So these are myopathic potentials. Then when you look at the turns amplitude ratio, you have more number of turns in the bottom, amplitude is less. So it's a clear-cut example of myopathic potential. With regard to the recruitment I mentioned earlier, we have, suppose the person starts contracting the muscle very, very gradually and grows on increasing. By the time the first unit has come to 10, you have second unit. Then when this one has come to 10, increases, then third and fourth will come. Whereas in neurogenic, what happens is that you have less number of motor units. So because of that, you may have only one or two or few of the motor units which are firing when required for the more force. And as expected, as the MEP cannot generate, motor unit cannot generate more force by itself. So what it will do is it will fire faster, as was shown in the previous example. And in myopathy, as the number of muscle fibers are, motor unit has same number of muscle fibers, but these muscle fibers are thin. So it's like the Lilliputans trying to do the work of Gulliver. So you'll require more Lilliput or the small fiber motor units to generate the same amount of force. Will have require more units. So you'll have early and complete recruitment in myopathy. So this was the example of 50 microvolts per division. So top to bottom is around 4 divisions. 400 microvolts is the peak-to-peak amplitude of this interference envelope. So this is myopathic recruitment. This is rested. Local contact with minimal force, you are getting more than 5 or 6 motor units are contracting. So this is clearly myopathic potential recruitment. So this is frozen. It's a saved screen. So amplitude peak to peak is less. This is the example of model 500 microvolts. So you see that 500 microvolts and peak to peak it becomes almost 2 millivolts or 3 millivolts. That is accepted. When you have more force being generated, 2 millivolt also, 2 to 3 millivolts and peak to peak amplitude can occur. But what you see is that there is no baseline seen except very few areas. And nowadays, at least I do not go for the full force. I just look at how much is the firing pattern and the firing rate and the motor unit characteristics. That will tell us most of the information that we require. Neurogenic with the interference, you have baseline which is C, peak to peak is almost 10 millivolts. This one is from here to here is 10 millivolts, 2 millivolts per division. This was the one example is just given. Incomplete recruitment or interference pattern with the large amplitude. This is a reinnervation with the neurogenic pattern. Coming to this F wave, recorded 80 milliseconds in sweep. The two abnormalities are 3 millivolts per division. So we'll go to the answer here. 3.2 millivolts is the amplitude of the CMAP. For median, 3.2 millivolt is less. Now, if you see this from here to here is just 3.2 millivolts. So reduction in the amplitude of the CMAP. So there is axonopathy. In addition, we have this F wave, single F wave, which is occurring with an amplitude of 1.5. So there is axonopathy and we have large F wave. F wave amplitude is more than what is recommended. So most of the F waves should be less than 5% of the M because at no time the whole muscle fiber is going to be receptive in the motor unit. The antihorn cell will not be able to send back the antidromic volley which has come to the antihorn cell and send it back to the muscle fiber, motor unit to produce F. So if this F is so big, almost 50%, that means there is a reinnervation of one unit, which is seen here. So this is a axonopathy. In addition, you have reinnervation, which can, this is to be identified. This is a single unit. Sometimes if there's only one motor unit, for example, in extreme patients with the late phase stages of MND, we see that M is 2 millivolt, F is also 2 millivolt, same as F. M and F will be almost identical. That is when you have only single motor unit which is there. Here there may be two or more motor units. So this is either axonopathy or neuronopathy with reinnervation of the one motor unit here. So here the latency was 34 milliseconds. So this is slightly increased latency. And amplitude 14.97, 1.47, 1.5. Slight variation is there because of the cursor placement. 34, F minimum, F maximum, there's minor variation. So F is useful for two or two more things. One is to look at the reinnervation also. Even before you put the needle, you know there's reinnervation in this patient. This is an example of a patient with the quadriparesis. We see that M latency is 1347 is the F latency. When you look at the raw data of the graph, we have a dispersed CMAP with the at 10 milliseconds per division is the sweep. We have the M, which is almost 15 millisecond duration. CMAP duration should be less than 8 milliseconds with the normal conduction. Even when you do F also, the duration should be less than 8 milliseconds. Distal latency is increased in the M, so there is either demyelination, in addition dispersion of the CMAP, F is delayed, so there is a demyelinating disorder. So these three things can be identified, both proximally, 13 point, residual is around 34 milliseconds is the difference between M and F. So we don't expect so much. Okay. So this graph was not shown. This is for median now. What we see is that M latency is 7.9. M amplitude is 4.0, this is borderline. F occurrence is 100. We see that all of the traces have F wave. And M is consistent. And the superimposed waveform shows that there is no variation. M is consistent, slightly reduced, but latency is 69. Now, this is at 10 milliseconds per division. So 1, 2, 3, 4, 5. So this is between 60 to 70 milliseconds is the F wave occurring. And if you see here, they are occurring at different times. Some of them are occurring early, relatively late, some of them are occurring late. and they have different morphology. So that means they are not occurring from the same motor unit. Some of them we have identical 3 or 4 sets here, but the striking thing is the increased distal latency, which is 7.9, approximately double the distal latency. And you can calculate the distal latency, the F latency is increased, so there is demyelination. 100% F, if the F is 100% in post-table now, that is acceptable. That's within normal limits, but whereas it cannot and it should not be getting 100% F in the median now. This is abnormal. There's human pathology in addition. Second thing is the latency. 69 is abnormal. Generally, we expect around 39 milliseconds. And you can calculate the distal latency, FA conduction velocity by simple formula, or you feed in the distance from the stimulation site to the midline, that is the anterior neck for the upper limb nerves, and the in the lower limb till the umbilicus, that is can be taken. So that is, and they calculated mean conduction velocity 39. So that is not only demyelination peripherally, as evidenced by increased distal latency, and you have slowed conduction throughout the median nerve axon going till the anterior cell. And because of this increased persistence, in addition to demyelination, you have probably UMN lesion, a possibility. So conduction velocity can be calculated by the distance multiplied by 2, because the impulse has to go from distal side to the anterior horn cell and come back. So distance becomes whatever the measured distance multiplied by 2. Denominator is F latency minus M plus 1. 1 millisecond is supposed to be for the turnaround time in the anterior horn cell, because part of it is due to the refractory period in the motor axon. It may not come back always, some only if it comes back. Now we'll give you the example. Distance is 600 milliseconds, F latency is 30 milliseconds, M latency 4. I made the thing simpler. So FA conduction velocity becomes 600 into 2 divided by 30 minus 4 plus 1. So 1200 by 25, 60 meters per second. Even if the system does not give, you can still calculate and tell, okay, is there additional slowing proximally or not? You can do the motor conductions, for example, up to F point. Sometimes it may become difficult in obese people. And in lower limbs, it's not possible to stimulate above popliteal fossa, except when you use monopolar stimulation, which is going to be obviously challenging. So you can use this formula to identify, is there any additional proximal slowing, or is the slowing only proximal, or proximal and distal can be identified. So coming to this graph, number 14. So wrist stimulation produced CMAP, which is slightly dispersed. When you went to the proximal side below elbow, this is we have slight reduction in the amplitude, but wave morphology became slightly shorter. Probably there is some conduction block. Now this potential here, this is from the median nerve, because this is occurring at around 11 to 12 milliseconds, much earlier than the below elbow stimulation. So what has happened here is that distal stimulation was at least 21 milliamperes, but below the elbow, we required 58 milliseconds. This is in the mid, above elbow, 32.8 milliamperes was the intensity. But that stimulus was given, we had this median of volume conducted impulse, with the median nerve was also stimulated at the same time because of the spread of stimulus. So this CMAP from the median nerve innervated muscle fibers came in, that sometimes will give a negative interval, because this sometimes automatically the cursor may go to this trace and give a very wrong value. So what happened was, we stimulated, recorded, we reduce the intensity to 17 milliseconds. So when you reduce the intensity without changing the stimulation site, this preceding the median or volume conducted impulses CMAP disappeared. So we have to be careful when you do the conductions. See to it that you use appropriate strength and appropriate site of stimulation to take away the confusions. Now this patient was the question, patient number 15. Lady with the person with the history of fall, brachial plexopathy, came for conduction around 3 months. You have a good CMAP, 9.5 millivolts. At the end of 3 months, patient is still weak. That means you still have axons which are conducting below the brachial plexus. So you have what has happened, there's a conduction block when you give the stimulation. So that means this person has highly likely, but the 3 months, if there's weakness and patient had significant weakness around grade 2 to 3 powers of power in the hand muscle, moderate to severe weakness, but CMAP is good. That means there's a proximal conduction block which is demonstrated. This person improved at the end of 9 months, 10 months with the near normal power. Conduction block, reduce CMAP and area. Supramaximal stimulation, we had to use 19 milliamperes. Even with the 19 milliamperes, we could not get through the conduction block. Conduction block can occur sometimes due to wrong technique. If you suddenly by mistake press a wrong button, which is reset button for the stimulation intensity, what you can see here is the zero intensity. Amplitude becomes zero. That is no stimulus came. So it can produce a pseudo-conduction block, that is technical. No stimulus given. And the 16th one, there are 2 or 3 things which are there. One is this is a first one is the wrist stimulation is a dispersed CMAP with multiple spikes in the CMAP. There are 1, 2, 3, 4 spikes. And when the stimulation was done below elbow, 2 spikes disappeared and a tiny spike preceding the bigger spike, bigger part of the CMAP. That means there's already conduction block of some muscle motor units or the some axons, not for the whole axon. This is when you have hundreds of axons, this sort of dispersed CMAPs will not be seen, but this is with the marked reduction in the same motor units. This is conduction block for 1 or 2 or 3 units here. When you went to the axilla, we have only this potential also disappeared. We have only tiny axon with the small motor unit, small muscle fiber, and which had a amplitude of 43 milliamperes, microvolts, whereas with the distal stimulation, the amplitudes were maintained. Velocities 10 meters per second in the forearm segment. Across elbow is 27, and in the arm segment, it's not the conventional conduction failure system across elbow. This is in the arm segment, there is a focal slowing which occurred, and in the forearm segment, and it is a relatively faster across elbow. So this is patient has multiple issues, and this probably was F, which is quite delayed. This is at 20 millisecond per division. So this is much delayed. Maybe F, may not be F, but it is too delayed for the system. So this conduction was shown. Median of conduction, the abnormality is not in the elsewhere. First response we see that 12.8, 10.1, 10.2. That is okay. Morphology is maintained. This fourth response looks totally different. F point. Now this has occurred because of the stimulation of the assistant nerve. What is the assistant nerve? Is ulnar. Both of them got stimulated. So look for the morphology. They should be looking similar. If the morphology is changed, totally out of ordinary, that means you are probably stimulating either nerve simultaneously, or there is a simultaneous spread. Edge point stimulation is fraught with this problem because the nerves are very, very nearer. So last but three. Now this is median nerve stimulation. I told this person had brisk reflexes and amyotrophy. What is demonstrated in the median nerve? This is the H reflex occurring. We have small m, we have H, m is increasing, then this also, this probably H or M, because these three are identical, this is totally different. So this could be F response. This person had CV junction anomaly, not this person did not have MND. Patient had CV junction anomaly, the high cerebral cord lesion, and the hemorrhage in the hand due to the vasculopathy of the spinal cord. So H reflex can be elicited in the upper limbs also. FCR is supposed to be a classical site, but if you are careful, you will be able to demonstrate this. So H reflex classically, when you go on increase in the intensity, first you get H, then gradually as the M goes on increasing, H will disappear, which can be shown in this cartoon. The white circles are the H reflexes. This is the black dots are the M response. M goes on increasing, H increase, then reduces. So this is the conventional H reflex, and this can be was demonstrated in the median nerve as well. Easily, commonly we are doing in posterior tibial now from soleus or gastrocnemius. So 19th example, we have increased distal latency 7.4. We have increased duration. This is almost 10 milliseconds. There's reduction in the amplitude, slight increase in duration. There's a dispersion when you go proximally, and conduction block is there by around 30%, then again 50%. So conduction loss. This person in increased distal latency, dispersion, partial conduction block, demyelination. So other examples, you need not always have conduction block. The distal latency here is 12 milliseconds. Duration is 15, almost double. Amplitude is reduced. Velocity slightly reduced. So demyelination is not in the forearm segment. It's slightly in the forearm segment. When you go to the arm segment, velocity is normal. So this person has a distal demyelination, can occur in DADS variant and other early demyelinating neuropathies. You can have normal CMAP duration distally with normal latency 3.97. You can have dispersion of the CMAP and conduction block both in area and amplitude. You can have what looks like a multiple serrated waveforms as a CMAP, wherein the latency placement for the duration becomes difficult. This onset, this is end. You cannot not going to place somewhere here. So conduction blocks, one more example, Allah now, with the stimulation in the mid-arm, there's a conduction block, and distally the conductions are normal. This is at 3 milliseconds per division. Sometimes there may not be any conduction block. You can see that 2.1, 1.3, 1.58, not much of change in the amplitude, not more than 50% reduction. But what we see is that the velocity across the wrist segment, 9.3 millimeters per second, whereas the forearm segment is almost 40 and the arm segment is 53. So from below elbow to above elbow, there is a big gap, almost 5 milliseconds. This is the interval that we have for the forearm segment. This one. This will skip. Last example, repetitive nerve stimulation. It shows reduction in the amplitude. So there is a decrement. Decrement, how much was it? The baseline amplitude was 4.3. Fifth CMAP is 2.9. Amplitude is almost 35%, almost one third. Area also it reduced. So there are some authors who use both area and amplitude. Some publications mention that area sometimes may be slightly better than the amplitude. Pickup rate becomes higher when you take the area. So we have decrement in the baseline test. This is 35%. After exercise, the amplitude, which was 4.4, became 5.9. So there is a increase in the amplitude, but not marked increase. This much increase is expected and can easily occur even in postsynaptic abnormalities. So as this is less than 50% increase in the amplitude, this is a postsynaptic disorder, and the decrement, which was 35%, became 25% after exercise. And when we continued up to 5 minutes, the decrement came back to 35%, 32, 35%. So this is decrement at rest within normal facilitation with exercise and the persistence of decrement. There's no pathological increment. This is to show a normal person with the normal decrement, which is around here, it's just a 0.5%, 0.1%. So if you do a proper stabilization, you will get a nice graph like this. Okay. This is a patient with the myasthenia, seropositive, not musk, but it looks musk, like musk. This is at baseline. We have decrement of 30%, 30%, 29, consistent decrement. So this is 500 stimuli. You can see the waveforms, increment, pathological increment. This was 107% increment was there. And this patient is on follow-up for last 3.5 years, came in during COVID time, 3.5 to 4 years now. 107% area increment was also there. Here it's seropositive, myasthenia, SHR positive, no thymoma, and he has done well completely only with the periodic segment for last 5 years. He was almost in remission at this juncture. So same patient, before exercise, 3.2 milliseconds, baseline, after exercise, 8.2. This was before the tetanic stimulation, which was given. By the time he was already on medication. I think that's it. So it's the last one.
Thank you so much, sir. Very lucidly and very simple. Made it very simple. Yeah, most people were putting in answers. I mean, I saw.
Okay, I did not see that.
Yeah, it's there, the chat box. Now I request Dr. Shruti to give your comments, and if you.
So many people have said there's myotonia. So
Yeah.
let us say next person made it nascent MUP with high amplitude. So this was for probably 10. No, there is a polyphasic MUP. Axon reflex. No, because this person had a large amplitude. So this is likely to be only renervation. So sometimes we get the same as condition block. Less than 5 hertz. Involuntary activity for the which one I don't know.
That's
Less than
okay,
5
sir.
hertz.
They have
Sir,
anyway.
it's
Shruti,
always very good to. You're very precise and
permission from you to put in that. That's okay. Sanu, stop it.
Okay.
Yes, sir. Thank you so much, sir. And I take your permission to put it in our YouTube channel. We have a channel there.
Yes.
So, yeah. Thank you so much, sir. This is
Okay.
not your second round will come up.
Okay.
Good night.
Thank you, madam. Good night.